Dr. Tash, thanks for joining the podcast. I'm extremely pleased to have you after some missed dates. So finally great to connect. So I'd love it if you could just introduce yourself and tell us a bit about who you are and what you do.
Well, thanks for inviting me on the show, Charis. And as I mentioned earlier, I'm sorry there's been a lot of hiccups along the way, but we got there. And that's the thing about podcasting. You just have to persist and it all happens in the end. So I'm a fertility specialist gynaecologist based in Sydney, in the inner west of Sydney, Newtown. I do a mixture of things as a general gynecologist. I see women from all reproductive age groups, from young, teenage adolescent girls to postmenopausal women. The bulk of my practice is in reproductive medicine, so helping a lot of couples trying to conceive, single women, same-sex women. So my focus is mainly on baby making, but of course, I, as a general gynecologist, I like to see a variety of gynae issues. And I also run a podcast, but I haven't put up a podcast for about a year because life's been so crazy. And I'm happy to get back on track with it this year. And the podcast is called The Fanny Mechanic. So podcasting is a lot of fun, but you do need to, real commitment and I suppose a formula to help it continue.
Yeah, that's right.
So, yeah.
So I first, I guess, caught up with you or became aware of you several years ago when you were speaking at the ACNEM conference, the Australian College of Nutrition and Environmental Medicine. So a couple of things. Well, there you were talking about your running. So a couple of things. One is, would you describe yourself as more of an integrative gynecologist? And also I'd love to know more about where you're at with your running.
I'm definitely, I suppose, an integrative gynecologist. And what does that mean? I mean, it means that I have a holistic approach to the way I see my patients. So I want to know everything about them, from how much sleep are they getting to their, food intake, their nutrition, their stress, what they do for a living. So I want to know every aspect about their health. But in terms of integrative, I work very closely with acupuncturists, Chinese medicine practitioners, naturopaths, dietitians, and I refer a lot to all of those people to help me manage my patients. So I don't feel like I can do everything for everyone. So as a doctor, you do often need to, refer people to other people to be able to maximize on their health and improve their health, to maximize on outcomes like falling pregnant and having a baby. Where am I with my running? My running pretty much stopped. When did I stop running? When there were bushfires in New South Wales just before COVID hit. So what happened was, I was an outdoor runner. I love doing the half marathons, and because of the smoke and the pollution in the air, I stopped running. And then I lost motivation. Then COVID hit, and then everything just changed. But last year I got into martial arts, so now I do Hapkido, and martial arts is just, blown my mind.
Really?
And, so you do have to be quite fit to do the martial arts. A lot of it is, about fitness, but also about techniques. It's just a very whole different thing, really. And it kind of fits well with my interests in Eastern medicine, because, as you're doing the moves, there's a lot of on acupressure points and pressure points, which is how you take down opponents, etc. But it's all also very much based on the meridians, and I've just found it absolutely fascinating. And the oldest person in the group is about 76. He's a black belt. And the great thing about martial arts, and I would encourage women to look into martial arts, because it is very holistic. There is a real focus on the mind, body, but you're in groups where you're training with people from all fields, backgrounds, women, men from different age groups, and it gets you really fit and empowered. So that's where I'm at the moment.
Did you know someone who was doing it? What made you head into it?
My little niece, well, she's not really little, she's taller than me. She's only 10, but she was really into that Cobra Kai series, and she said she wanted to get into martial arts. And I also have a good friend who was doing it with her daughter. And I thought, well, I had missed the fitness that I was into. When I was into running, it was a great thing. It made me feel good. And then I realized I'd become this sloth. I wasn't doing anything fitness wise. And I thought, really, I've got to do something. What can I do now? And I thought to myself, am I too old to, I'm 48. Am I too old to start something new like Hapkido, which is completely different to what I've done in the past? And I'm like, no, I'll just turn up and see how I go. And I was hooked from the first trial session. So, yeah, I hope to get to black belt. It'll take me at least 5 years. But that's the goal.
I heard a quote recently, which I can't even remember where it's from, but the difference between a white belt and a black belt is just consistency, which I really like.
Yeah, I mean, they say the black belts, when you get your black belt, that's when the fun begins.
Okay.
I think, yeah, consistency. Yeah, right. You're right. Keeping it up, keep turning up. I think keep turning up. Even there are days when you might not feel 100%. Just turning up and doing what you can on the day is important. And that's the same with running. When you run, I find that there were days when you'd want to go, oh, I'm going to do 5Ks today. But then as you're running, you're like, you know what? I don't really feel like doing 5K. I might just do 2K, but at least doing 2K is better than doing nothing.
Yeah.
And as a woman in her 40s, so I'm perimenopausal because I'm 48. I don't need to do a blood test to tell me I'm perimenopausal. I know based on my age that I'm perimenopausal. Doing things like martial arts is great for me because, you do a lot of push-ups, sit-ups, a lot of strength training, and a lot of it's body, it's your own body helping you do that, so you're not using equipment necessarily to help build strength.
Yeah.
And it keeps the mind nimble because you're doing different things each time you go, which challenges the brain. And yeah, so I'd encourage people to not be scared of doing different things, even as they age.
Yeah, it's a great reminder. Thanks for that. Absolutely. I'm curious with your infertility work. So there's been a real crescendo in infertility rates and the need for infertility services in maybe the last 20 years. What do you think is the driver of some of that?
You mean, why is it that people are needing
this
services more?
Yeah.
A variety of reasons. Women are getting older. They don't necessarily have to hook up with anyone because financially women don't need necessarily a partner to move through life. Yet, of course, a lot of women want to find the right person, and that can be harder. So female age, the open-mindedness around being a single mother and women using donor sperm through clinics, same-sex couples, the same thing. Younger women also wanting to freeze their eggs, which is also becoming more socially acceptable and discussed and talked about. Transgender patients wanting to freeze their eggs or sperm. Yeah, quite a variety of reasons, really.
Yeah, interesting. Do you find so one of the questions I've always had is, say, girls going on the pill at a young age that may end up staying on it for 25 years, potentially consistently that whole time. how much does that impact infertility issues? They often say, for example, that it will take 5-6 years for a girl's menstrual cycle to settle when she first gets her period, and that if you interrupt that, for want of a better word, with the pill during that first 5 years, that when she comes off it maybe 25 years later, that there's still that the remaining 3-4 years for that to catch up time before she might be able to come pregnant. What's your perspective on that?
I think it is a concern when young girls around 14, 15 go on the pill. It's different if they need contraception, because contraception, of course, is super important for younger girls, and we know younger kids are getting sexually active. It's more likely these days. So firstly, you don't want a kid falling pregnant. So you've got to ask yourself, what's the indication for the pill? And I think contraception is a good indication. But of course, those young girls need to know that the pill will suppress their natural cycle. They will have artificial withdrawal bleeding. It will not be a natural process. That they may develop anxiety and depression. The younger they are put on any form of hormonal therapy, whether it's the Mirena IUD, the Nivarine, the combined oral contraceptive pill, the Depo-Provera. A woman's periods tend to be irregular for the first 2 years, and then after that they settle. They should become more regular and in a more regular pattern. However, what I do find is a lot of younger girls now are becoming more obese and overweight at a younger age, and that can impact on cycles. That can lead to irregular periods, and not always necessarily polycystic ovarian syndrome, which is what people automatically label someone as when they have irregular periods. Of course, other causes of irregular periods include, under eating, over exercise, the performance issues around that, and also eating disorders, bulimia, anorexia, quite common in that age group, which can then cause irregular periods. So I'm not totally against the combined oral contraceptive pill, because it can be very, very important for some girls to be on it for a variety of reasons. But I think it's just important that they get a full perspective of the pros and cons of being on the combined oral contraceptive pill for a long time. And I would recommend that people consider going off it for a few years at a time if they want to be on it, just to see how their body is without it. Because, what I often do see is women who've been on it for a long time, they don't know what a natural period is. They don't know what it means to ovulate, the signs of ovulation. So by the time that they want to conceive, they don't know how their own body works. And we do know that the longer a woman has been on the combined oral contraceptive pill, the longer it takes for her to conceive. And whether that's because, she's on the pill for such a long time, she may have had underlying issues like PCOS, etc., and that were never addressed.
Yeah. Okay. So it is a consideration for infertility issues in someone in their mid-30s if they've been on the pill for a long time.
Yeah, I wouldn't say the pill causes infertility. I don't think you can say that.
No, okay.
What it does is it's like a bit like a Band-Aid. You cover things up and not really know what's going on underneath.
Yeah. Okay. Yeah, interesting. So what about just, I guess, fast forwarding a few years to around menopause? So you indicated yourself that you, just by your age, you don't need a blood test. So for someone who might not necessarily be as intuitive, what sort of symptoms would they be looking at from a peri/menopause perspective to know?
It doesn't always go to the period straight away. Mood changes, more anxiety, depression, sleep disturbance, weight gain, particularly around the abdomen, the mid area. And then, of course, period changes. So periods can become heavier. There can be, I call it the accordion. So like an accordion that opens and closes, cycles might be longer. So there might be longer time between periods, and then suddenly the periods are coming more frequently, and then they become more irregular, and then they eventually stop. Low libido, issues in the bedroom, dry vagina, lot of skin changes, more acne, more hair growth, you name it.
And is that the elevations or the fluctuations in estrogen that's driving that? Is it the drops in progesterone that's driving that when ovulation isn't happening each cycle? Is it a combination of both?
It's a combination of everything. So hormones don't work in isolation. You can't just blame one hormone. It's usually what one does and how it interacts with the other and impacts the other.
Yeah. So I wanted to talk about, it's commonly referred to as hormone replacement therapy, but I have an issue with that because I hate the perspective in menopause that your reductions in hormones need replacing, because actually it's a normal process for your hormones to reduce. So maybe like more of a menopause therapy. What are some of the considerations people might have for that? Like, first of all, what are the options? When might someone decide that they might need some therapy in menopause to help with symptoms?
Well, now we don't call it HRT, it's MHT, menopausal hormone therapy.
Okay.
And it's a very individual thing as to when to start, what to start. The great thing is there are a huge amount of options, and it depends on what phase of the perimenopause, menopause of women are at. If they're in the first initial phases, all you need to do is sometimes give them just progesterone. It depends on their symptoms. If it's dry vagina, then if lubricants don't work, then you give them topical estrogen. If they're getting really bad hot flushes and night sweats, then you could consider non-hormonal therapies first, like herbs, like cognitive behavioral therapy, exercise, etc. But in my experience as a fertility gynae doctor, nothing beats and comes close to replacing with estrogen and progesterone.
Mm-hmm.
If women want to find out more about menopausal hormone therapy, a fantastic resource is the Australian Menopause Society website. And I don't think anyone needs to go beyond that really to get good information. And the great thing is it's Australian, and there's a really good outline on all the different types of options, whether it's gel applications, oral tablets, patches, vaginal therapies, you name it, non-hormonal therapies.
Can you talk about some of the historical anxiety around menopause hormone therapy with, is it Premarin years ago?
That was the big studies that came out in the early 2000s, looking women basically in their 60s. Lots of flaws in those studies that used a certain type of estrogen and a certain type of progestin, which aren't really used today.
Okay.
Showed that there was an increased risk of breast cancer in women, and that really freaked a lot of people out. The media took to that before doctors really knew about it, so the doctors were kind of inundated with patient concern. Since then, there have been multiple studies that have come out that have rebuked and really refuted a lot of the claims in that study. But it was really a big kind of black mark around menopausal hormone therapy to the detriment of a lot of women. And to this day, there are still concerns around it because of that study. So again, if people go to the Australian Menopause Society website, they can look up all the information related to that, the pros and cons of menopausal hormone therapy, significant benefits when it's commenced within 10 years of menopause, and the pros far outweigh the cons.
If you're quite symptomatic.
Yeah, but even if you're not symptomatic in terms of bone health,
yeah, okay.
Particularly, brain health. I'm a big fan of menopausal hormone therapy. And thankfully, there are lots of options for women.
Yeah. Do you use or what's your headspace on using SSRIs or sort of antidepressants, not necessarily for depression, but just from a serotonin boosting perspective with the estrogen, the loss of estrogen, how that interacts with serotonin?
I'd only ever really recommend that if someone had a contraindication to menopausal hormone therapies, estrogen and progestins, for example. Most of the time, it's the GPs that take that on board.
Okay.
I rarely prescribe SSRIs. They're generally used as an anti-anxiolytic, antidepressant, for example,
Yeah.
and are not really my field. But I try a lot of other different things before going down that path or recommending they see their GP around that. Of course, if a woman does have anxiety that's significant, then people should not be totally scared about going on those meds either. There are lots of issues potentially on going on those medications because they can cause issues with insomnia, low libido, weight gain, and coming off them isn't always easy. So that's why I say look at non-hormonal options first. Look at your lifestyle, your sources of stress, how you eat, how you sleep, who you interact with, what your mindset is before going on to any medication.
Mm. How do you find the impact of exercise for women during peri and menopause stage?
Significant benefit for women from a mental and physical perspective. It should be a standard part of the treatment of the perimenopause and menopause. And as you probably know from Stacey Sims' course, that we lose muscle and our bones can be impacted by the or are impacted by the perimenopause and menopause, and we do need to focus on spending time doing more strength training, whether it's kind of body resistance or using heavy weights to encourage that, and to also maximize our insulin sensitivity so we don't develop diabetes and issues with hypertension and all the other things that go with ovarian aging.
Oh, that's a horrible phrase.
Well, I think that's again is a mindset thing, isn't it? Aging is it always a bad thing?
Oh, it's just ovarian aging. It's
yeah, it's life, as Darren Hinch used to say. That's life, and I find a lot of women, they struggle with aging, and what really concerns me is that we live in this society now where a lot of younger people are having things like Botox, are having things that are altering the way they look. And I often look at them and think, how are you going to age? What is going to happen to you when you hit your 60s and your 70s? Are we going to forget what wrinkles look like? And I find that quite sad. And it's the acceptance of, hey, well, you know what? There is a lot of grace, and you can age gracefully. And it does make me sad, and it does concern me when I see this, as I see it. I think there's a real fault in society. I could go on about it for ages. But I wish women would embrace themselves as they age, as they get older, and accept that, I will be gaining some weight when I go through the perimenopause. Up to 5 kilograms is normal and acceptable. It's my body's way of protecting me, and just acceptance, a bit more acceptance and self-love, and not wanting to be the 20-year-old wearing the short skirt and the midriff. Anyway, don't get me started.
So just to touch on something you just said then, that up to around 5 kilos is okay, and from a protective perspective, can you elaborate on what you mean by that?
Well, excess, body fat is a hormone. It makes hormones. It's a hormone factory. It makes a type of estrogen.
Does it make E2? Makes E2?
Not estrogen. There's estriol. There's different types of estrogens. It makes.
Yeah.
I think it's. I should know this. Estrone.
I think it is
makes
E1 it might make. Yeah.
a weaker type of estrogen.
Yeah.
Estradiol is the one that predominates when we're in our reproductive ages. As
Me
with
too, yeah.
age, there's one made majorly by the placenta and another one by body fat. So, and also it does act as cushioning. If I fall when I'm a bit more pudgy around my hips, then that might protect me from injury, from fracture.
I was reading an article recently, I can't remember exactly where it was as well, that weight gain and some fat on the thighs is actually particularly beneficial from a cardiovascular perspective rather than abdominal, which has always been like poo-poo. But where you get the fat too is obviously it's not that getting fat is, or getting fatty deposits is bad, a blanket bad thing. It's where it goes also affects risk.
Well, that's right. But unfortunately, most women who become perimenopausal, menopausal will gain weight around the mid area. Yeah, which is why they have increased risk of cardiovascular issues.
And hence,
a cardiologist will be able to tell you more about that.
Hence why I guess menopause hormone therapy is often encouraged too from the cardiac benefit side of things.
Yeah, within the first 10 years of commencement.
Yeah, okay. Yeah.
What medication you would prescribe someone really depends on their if they have any medical issues. So every person is individual and should be treated as an individual when they go and see their doctor to discuss menopausal hormone therapies.
So from an exercise perspective, when you did your talk a few years ago, you talked a lot about the impacts of the menstrual cycle on not running per se, but how your body responds to exercise in each of the various stages. Can you, if you can recall from that talk or your daily work, just break some of that down?
Yeah, so women tend to feel best in the first half of their menstrual cycle, so pretty much from their period finishing to ovulation. Around the time of ovulation, there's an increase in testosterone, which increases libido, which makes sense biologically, because if you have an increase in libido, you want to have sex and then conceive. But that increase in testosterone also helps with mood and energy. So we feel more energetic when we're doing any form of physical activity. And following ovulation, what happens is testosterone levels drop significantly, as do, and that parallels the rise in progesterone and a relative drop, but still rise in estrogen. And that can be hard for some women because what happens is progesterone increases body temperature and our core body temperature, and that in itself can make it feel harder. As you know, when you're running, you feel hotter. It may also impact on sleep, so we're not sleeping as well, so we feel a bit more lethargic, and we make different decisions around our food intake. We're more likely to eat carbs, etc. And I think knowing where a person is in their menstrual cycle can empower them to make different decisions around what type of training they will want to do. And you would probably know a lot more about it now that you've done the Stacey Sim course or are doing that, and in the world that you're in at the moment, Charis. But I always encourage women to really just be mindful of what it means to be in, say, your second half of menstrual cycle. Do you need to be doing more things like yoga, yin yoga, taking it more easy on yourself, and having different expectations around that? Maybe you're going to find it more difficult running when you're 2 days before your period as opposed to 2 days after your period. And I certainly remember that when I was doing my running, I was very mindful of where I was in my menstrual cycle, and I definitely found it more difficult doing things in the second half of my cycle. I would make sure in that second half that I would take things like magnesium, focus more on sleep, getting to bed earlier, and not pushing myself so hard in the second half. and knowing that our hormones impact how we feel on a daily basis. And a lot of women don't have a sense of that. They really don't. It's because they've never looked into it. It's not talked about. But I definitely made a point of bringing it up when I was in my running group. I used to run with a group of women called Boobs on the Run. And I wanted to make it a very much a topic of conversation each time we turned up for a run. Why are you feeling tired today? Is it because you're losing all this blood, you're on a period, you're fatigued, your iron stores are significantly low, and that's the other thing that women don't realize is that perimenopausally your periods may become heavier, you will lose more iron if you exercise a lot, particularly say running. Your iron stores will be more depleted because you lose iron through your bowels, your sweat. And, if you do things like marathons, you will definitely lose a lot more iron. So iron supplementation is super important. And I would encourage women to be mindful of how they get iron in their diets. A lot of vegan vegetarians out there may not realize the importance of iron intake, especially if you're perimenopausal. Obviously, when you're menopausal, you're not losing blood every month, so it's a different story there. But iron deficiency anemia is something I see a lot of, and it's a common cause of fatigue, common cause of feeling like shit, literally, which again is not very much discussed. So what I would love to do is to have people, whatever exercise they're doing or form of activity, to talk about it. When I was doing my personal training, again, when I was running, I used to talk about it all the time with my trainer. And I would always tell him, I am in this phase of my menstrual cycle. And I would educate him. I would make it my job to tell him about what my situation was, so that then with all his other future female clients, he would do the same thing. And even my Hapkido group, I'll bring up the fact that, hey, I'm in my period now, and I feel a bit meh. This I don't want to lie on my chest because my boobs are sore today, and that's why the reason why is because I'm perimenopausal, and I'm also premenstrual, so my boobs are feeling sore. I will not lie down and do this certain exercise, and I will bring that up in a dojo full of people, men and women of different ages. Do I care if that makes them uncomfortable? No, I don't, because I find it's my job to educate people, and also, to give people a bit more of an understanding of the female body. So that's my take on that one.
That's so good.
Yeah.
I wanted to ask you your perspective on blood testing for women who might be perimenopausal. What's the value add in blood tests for that stage? Well, I don't mean from an iron deficiency perspective, but just to see, are they in perimenopause? Are they not?
I don't do blood tests often to check hormones, because often hormones fluctuate, and you can do a hormone level one day and it could be within normal range, reflecting that they don't look menopausal or perimenopausal. So I will usually go on their symptoms. And I would find it more important to check for things like thyroid function, full blood count, iron stores, liver function, kidney function, vitamin B12 levels, vitamin D levels. I find all of that in many ways more important than measuring hormones.
Do you find with women who are iron deficient that they're quite, do you like iron infusions, or do you prefer to orally replace? I find that patients I've had who've had iron infusions, I've given a lot, it's quite inflammatory for people.
Well, look, it depends on the level of iron deficiency and the symptoms. There are things that can cause iron deficiency that affect the gut, whereby it means that oral supplements may not work as well, like celiac disease, Helicobacter pylori, and inflammatory bowel conditions. You want to probably maximize what they get in their diet, but that could take a lot longer for the iron stores to restore using that method. Oral supplementation can, wreak havoc on people's guts as well, can cause constipation, nausea. Iron infusions can be really helpful for people. And I think you've just got to lay it out to the patient, the pros and cons of each option. Obviously, there are risks to an iron infusion, the biggest one being anaphylaxis. But that's not that common, thankfully. And obviously, the skin staining is also a potential issue. But in my experience, iron infusions can be very important.
Yeah.
And very
yeah, I mean, I think absolutely. It's just that I've seen sort of flares of different things with iron infusions, and I guess I've got a concern that sometimes we rush to iron infusions because it's so much more convenient now than it used to be, and especially with the Ferinject, which is seen as being a lot less of an issue, but I do see a lot of still inflammatory responses with Ferinject, and I just feel like sometimes do we rush to iron infusions too quickly for people that are low in iron before we really give them a chance to build their iron up?
Well, what's rush mean? You usually rush it when it's really low. So what you want to do is
that's reasonable.
You want to avoid getting to that really low, which is why monitoring regularly is really important, so that it doesn't become so low that the first thing you think about is iron infusion. So if someone has a ferritin of 5, I'm going to recommend an iron infusion.
If
the person's got a ferritin of 5 and they feel awful, we're not going to waste time giving you oral supplementation. If you're a mother of 3 kids and you've got a full-time job, you want to feel good as soon as possible. So I think we put ourselves in that position, where we have to rush, and that's what we need to avoid.
Well, I think I've covered everything with you today that I really wanted to cover. Is there anything that you feel would be helpful to mention, or?
Well, I think just whatever it is that you do for exercise, think about your periods and your menstrual cycle and how it might be both will impact each other, and don't be shy in talking about it to other people, whether it's your personal trainer, other people in your exercise group. Normalize it.
Yeah, absolutely. Yeah, it's good. Thanks, Dr. Tash, the fanny mechanic.
Thank you, Sharon.
What's your Instagram? And so your podcast is the fanny mechanic?
It's the fanny mechanic, and it's on Spotify, Apple, etc. Hopefully I'll get some new episodes out this year. And I take a social media pause for at least 3 months every year, and I'm still off social media, but I'll be back on as Dr. Tash Fanny Mechanic on Instagram as of February. I think I said I was going to go back on. Okay, that's great. Well, thanks heaps. Thanks so much for your time. I'm glad that we got to connect, and there's definitely some nuggets in there that hopefully people can take away and feel more empowered for their own journey, and questions that they can take and ask their own GP. So that's good. Yep. Thanks, Cheris.